Good morning.
Good morning.
Welcome to the Wilson Center. I'm Sarah Barnes, and I lead the Maternal Health Initiative here at the center. For those of you who are not familiar with the Woodrow Wilson Center, we're a living memorial to President Woodrow Wilson, who remains the only president to have earned his PhD. That may change in upcoming years, but as of now, it stays true.
Oh my goodness.
Yeah, so the Maternal Health Initiative is one of the programs here at the Wilson Center, and we really focus on ending preventable maternal mortality and navigating gender-based health issues through independent research, actionable ideas, and open forums like today. Today's event with Saving Mothers Giving Life is really central to MHI's mission. I'm very grateful to be part of the launch of the Global Health, Science, and Practice Supplement on Saving Mothers Giving Life. The supplement is now published and available on, the Global Health, Science, and Practice Journal homepage. Congratulations to all of us involved in this work, and most of the writers and researchers are here on our panels and in our audience. So thank you very much. Thank you to all the panelists for making the efforts to be here today, for all your work on the supplement and your work towards ending preventable maternal mortality. A special thank you. I'd also like to give a special shout out to Dr. Claudia Morrissey Conlin, the U.S. government lead of the Saving Mothers Giving Life program, for coming to the Wilson Center for this launch. She is here in the first panel. And also, yes, Claudia. Yay. And also to my colleague, Amanda King from the Maternal Health Initiative, for all of her help in putting this event together. Yes, Amanda. She'll be at the camera today, so smile for her. Today's event will have two distinct panels. The first panel will be focused on SMGL's approach, the implementation, and the results. And the second panel will discuss the partnership, cost effectiveness, and sustainability. And we'll do a very quick swap out of panelists and speakers and moderators in between the two. There will also be a distinct time for question and answers from the audience after each of the panels, so you will have time for your questions. And for those of you watching on the live webcast, you can send us questions at @Wilson_MHI. So now I would like to turn the event over to our moderator for the first panel, and that is Carrie Hessler-Radilect, and she is the president and CEO of Project Concern International. You can find Carrie's bio and all of our participants' bios outside of the auditorium. So thank you again for coming. I turn things over to Carrie.
Thank you, Sarah. And it is just such a pleasure to be with all of you today. It's like old friends week or something. So today you're going to hear some remarkable results in the implementation of SMGL, Saving Mother Giving Life. But before we do that, and anyone who knows me, I have to start with a story, because behind every single statistic is the story of a mom and her babies and her family. And every single one of us has a transformative story that set the course of our lives. So I'm going to share mine with you. And that was my Peace Corps story when I was a volunteer in Samoa in the early 80s. Every Peace Corps volunteer is given a host family. And my host mother was Losa, and her husband was Vianney. When I arrived in Samoa, I was 24 years old, and Losa was 32. She was 8 years older than me and already had 8 children. Her first child was born when she was 14 years old. Now, the moment I got there, she started peppering me with questions about family planning, because she could not understand why I had been married for a year and did not have any children, was not pregnant. She thought something was wrong with my husband, actually, but anyway. And I explained that we were using family planning, and she told me that her husband would never permit her to use that. So one day after I'd been there about 6 months, I came home from school. I was a teacher. And Losa was there, and she was sobbing, weeping so hard. It was the kind of cries that where you can't even get your breath. And I thought her child had died, or her husband had died. And when she finally could compose herself enough to tell me what had happened, she told me that the reason for her tears was that she just found out that she was pregnant again with her 9th child. And she did not know how she was going to go on. Her youngest one, Pita, was only 14 months old. Now, I knew nothing about childbirth or prenatal care or anything. I was a political science major. And, but I did know that when my mom was pregnant, she had prenatal care. She saw a doctor, in her case, and she delivered her baby at the hospital. So I told her that, and I shared that information with Vianney, her husband, that evening, because we lived with them. And Vianney told me that although he would permit her to go to a clinic, and there was a clinic in the town, even though she had never, ever been there, every single one of her kids had been born on the floor of her home, 8 children, attended by her mother-in-law. She'd never received any kind of antenatal care. But Vianney said, yes, okay, she can go to the clinic, but she must deliver her baby at home, because the first faces they see, the baby sees, when they are born, have to be the people who love them. And whatever happens is God's will. Anyway, we went down to the clinic that next day, and the midwife there was a phenomenal woman who totally understood the culture, and she understood right away that Losa was at very high risk. And so she started scheduling Losa at the very end of the day so she could walk back with us to the home and sit down and talk to Vianney, the husband, and the mother-in-law, and talk and get to know them. And at first she talked to them about the weather and about the rugby scores. They gossiped about the priest, and they talked about everything except her health until she had developed a relationship of trust. And then finally, at about the 7th month, she started talking about the importance of delivering her baby in the health facility where she could get care. And she started to talk about the risks that she faced and what it would mean for Vianney and his family if she was not able to survive the pregnancy. And so eventually, literally in the 8th month, he finally agreed that she could deliver her baby in the health facility. So on the night Losa went into labor, we piled her in the back of a pickup truck, drove her down to the facility. Beautiful baby Margarita was born within 5 minutes, and just a few moments later, she went into postpartum hemorrhage. She absolutely would have died if she had not been in that facility. Now, thankfully, all the 3 delays that characterized her previous pregnancies had not happened in this pregnancy. Losa was in a facility with an exceptionally well-trained provider who really understood the cultural barriers and worked hard to overcome them. They had access to blood supply, and they had an ambulance that took her immediately to the hospital where she had emergency obstetric and neonatal care. Losa survived that pregnancy, and that baby born in that pregnancy, Margarita, is now Samoa's leading female lawyer with a practice that focuses on women and children, where she fights every single day to make sure that women in her country are able to receive a full range, a comprehensive range of sexual and reproductive health services, just like what SMGL is advocating. So this story illustrates the importance of our work, the things that we do. Now, SMGL, Saving Mothers Giving Life, is the whole of government public-private partnership, so you cannot imagine how happy I was when my dear friend, Claudia Morrissey Conley, called me when I was director of the Peace Corps and told me about this. It was just at the beginning, and wanted Peace Corps to be a partner with that. And we were so happy to join with the other partners, the other government partners and private sector partners. And our Peace Corps volunteers were working in Zambia and Uganda, and we're really focusing on being catalysts at the last mile, focusing on the safe motherhood action groups, helping to coordinate and mobilize transportation resources, helping to reinforce life-saving information, in much the way I did, although completely untrained I was. But they were well-trained, and they felt very much a part of SMGL. My organization now, PCI, is very proud to work in Zambia, where we support Peace Corps volunteers and community health workers and other professionals at all levels to make sure that there's quality of health care, there are quality of emergency obstetric and neonatal care, that we work with the military in making sure that there is we help with the Helping Babies Breathe, kangaroo mother care, as well as we work on the referral systems and transportation systems to make sure that women are able to really access a full range of services. Saving Mothers Giving Life has saved countless lives of mothers and children around the world. And as we all know, that when you save a mother's life, you save the life of the family and the community. So the approaches and lessons learned from this amazing and extraordinary program is what the content of this panel is today. And I'm so very thrilled to be here with our very distinguished partners. you've already heard reference to Claudia Morrissey Conlon. She is the head of the Saving Mothers Giving Life for the U.S. government, working as a maternal and newborn health advisor at USAID, and she has devoted her entire life, and I've known Claudia for a long time, to ensuring gender equity and full and complete access to maternal and newborn care, and we're so very grateful for your work, Claudia. Next to her is Diane Moroff, who is a medical epidemiologist at CDC, and she specializes in surveillance and the evaluation of programs to reduce maternal and perinatal mortality and morbidity, and we're so glad to have you, Diane. And then finally, we have Dr. Florina Serbanescu, who is a team lead for Global Reproductive Health Evidence for Action at the CDC, and she specializes in tracking the causes of maternal and neonatal mortality globally, and we're very delighted to have you as well. So each panelist is going to present their work, and then we're going to have, following all of the panels, we're going to have a moment for Q&A. So I really ask each of you to have your questions ready, because we want this to be as interactive as we possibly can. So Claudia, you're up first.
Okay.
Each panelist has a short period of time. I'm going to try not to interrupt them, but I am keeping an eye on the clock. And I'm so looking forward to hearing what you all have to say.
Thank you, Carrie. It is so great to be here, isn't it? With old friends, acquaintances, people who have spent their lives working on this issue and other important health issues. This is the culmination of about 8 years of effort with Saving Mothers Giving Life, and we are so pleased to be here at the launch of the Global Health Science and Practice Journal supplement on SMGL that came out yesterday. To say that we're excited is an understatement. I think the operative word is giddy, if you'll allow that, because we are happy to be able to share this opportunity with all of you. I hope that each of you has picked up a copy. I think we now have more out there. Yeah. Sarah's holding, Sarah, I'm going to hold it up high. Everybody make sure you get the copy. Now that copy only contains the editorial and the synthesis paper, the first 2 papers out of the 12 papers. And so please do follow the URL to the Global Health Science and Practice website and take a look at those other 10 articles. I think you will be happy that you did that. This morning, I'm going to briefly cover the sort of the genesis of SMGL, the theory of change, and also some of the guiding organizing principles. The other panelists will get to do the fun stuff, talking about implementation, and Florina will talk about results. So let's go ahead and get started. Okay. In 2011, the Office of the Global Health Initiative within the Department of State was tasked with designing an endeavor that would bring public and private expertise and investment together, and committed Ministry of Health leaders in sub-Saharan Africa together to address preventable maternal mortality. It was felt that a highly visible, well-financed, bold initiative similar to PEPFAR was needed to inspire and recruit new public and private actors to the cause, to mobilize new resources, and really to energize the global health and development communities. The design team was made up of MNH and HIV technical experts in project development, implementation, costing, policy formulation, and monitoring and evaluation. The resulting initiative was Saving Mothers Giving Life. I guess I'm doing that? You're doing that. The goddess is doing that. Okay. The Saving Mothers Giving Life initiative is a public-private partnership. It's composed of 6 U.S. agencies. So we had the Global Health Initiative, we had CDC, the Office of the Global AIDS Coordinator, Peace Corps, DOD, and it was led by USAID. We also had the Government of Norway, Merck for Mothers, Every Mother Counts, the American College of Obstetricians and Gynecologists, and Project Cure. Okay, working. The initial aspirational goal for Saving Mothers Giving Life was this reduction of maternal mortality of 50% in 1 year. Most of us rolled our eyes at that. Some other people had things to say that probably I can't say this morning about that. But the notion that there needed to be this aspirational goal that would really bring together many different cadre of people to work their hardest and see where we could go, I think was laudable. SMGL would work towards the goal by using an approach to district health system strengthening called addressing the 3 delays. The first delay is, of course, the decision to seek care, to reach care in a timely manner. And delays in receiving high-quality care. Well, all of you know this. I mean, all of you are technical experts. And the reality of this 3 delays approach, has been around for 25 years. So we really tried our darndest to find something more au courant, cutting edge, all of the adjectives that we all have to have in our armamentarium as development people. But we decided that this particular model, because it addressed both demand side and supply side issues, the barriers that block women from life-saving care, and it took a systems approach, that because of this, it actually was quite ideal for the Saving Mothers Giving Life project. So we adapted this in several ways. First of all, we decided to focus our work on all pregnant women in a designated area in Uganda and Zambia. Those were districts. In Nigeria, those were LGAs. Because we realized that trying to build a program around a subset of hypothetical women who have complications does not acknowledge that complications in childbirth are often certainly unpredictable and unpreventable. And so we also know that those complications can arise very quickly, and they can cause women to die also very quickly. So our cohort of interest is all of the pregnant women within the SMGL districts and LGAs. The second way we modified the 3 delays framework was that we added a time dimension. Our esteemed members from ACOG, who were our technical advisors, said that a 2-hour survival window was what we should shoot for. And so that dimension indicates that we will aim to have every pregnant woman in the district of interest to have access to emergency obstetric care within 2 hours. And the third way that we adjusted this somewhat was that some of the interventions don't fall neatly into the buckets, the 3 delay buckets. We also added some health system strengthening interventions, such as being able to use DHIS2 more capably, MPDSR, have skills around blood banking, this kind of thing that actually builds the system. And with a few more tweaks and a slight budget for a graphic artist, we came up with this theory of change model. And basically, it's your standard theory of change model. We have the inputs, and the inputs in our case are the foundations upon which SMGL then would add its interventions and expertise. So that's the government of Zambia and Uganda health system, USG PEPFAR MCH platforms, and private and public providers in the area. Next, we have interventions that are earmarked to address each of these of the buckets, plus health system strengthening. And we felt that if these interventions were successful, there would be 4 outcomes. And the outcomes would be increased use of services and improved self-care, timelier access to appropriate services, improved quality of care, and a strengthened district health system capacity. And if these were done together, it doesn't mean lockstep, but the intention was to think about the system and the inputs that you need to strengthen the entire system, then we would anticipate that the designated population in that district would see a substantial decrease in maternal mortality, and that, in fact, is what we did see. So implementation of the this theory of change followed what we called organizing principles. It was sort of, how do you think about doing what needs to be done? The first was that we wanted to use the whole market approach. This acknowledges that both public and private providers form part of this maternal health safety net in a given geographic area. And so one needs to assess and really ask the private sector to join along with the public sector in order to strengthen that safety net for a woman. We often say that as a woman, if you're looking out and thinking, where should I go to deliver? It's less about public-private. It's about where can I find transportation? How can I pay for services? Where is the quality good? Where will I not be disrespected? And so having this, like to call the ecosystem of safe motherhood in a district is imperative as the basis for the work that we did. We like to improve the services during the most vulnerable period for mother and newborn, and you know that is labor delivery in the first 48, 72 hours post-delivery. The third is we tried to integrate HIV and family planning and MNH services. In the areas where we work, midwives were the primary providers, and so they were providing each of these services, but often on different days at different times. And so we attempted, particularly around the HIV services, to have those part and parcel of our MNH so that a woman who is seropositive could be placed on antiretrovirals, that we could prevent PMTCT happening with the babies, the mother-to-baby transmission. So that was one of our key operating principles, to think about trying to bring these together for the woman. Rather than distance to care, which has traditionally been the way that we've thought about how do we rationally parcel out our resources and how do we make our services more available to women, we considered travel time as a more important parameter than distance. ACOG recommended, as I said, this 2-hour survival window. And so, for example, in Uganda, we used travel time mapping, which is the software, to understand where to put resources in order to make those women in the catchment area have the ability to reach care in 2 hours. So it allowed us to rationally use our finances and our technical inputs. And the last is count and analyze and report all maternal and perinatal deaths, along with the cause of death. We all know that's hard to do, but what we found was that it really fostered this high level of awareness. We had the health commissioner in Lundazi who said to me, you know, women used to die in secret, and now we hear about a death before lunch, and we're expected to have a plan before dinner. People knew there were political consequences, not just health people. He was the commissioner, not the health commissioner. People know there are consequences to a lack of action. And so bringing this back to the community leaders, the politicians, the parliamentarians, that is sort of an added benefit that happens when you start to rigorously capture, analyze, and report on deaths. All right, how am I doing on time? Okay, and that was what I just said. Okay, I have 3 minutes. This is the SMGL countries and phases, basically the 2 countries that were selected in 2011 were Uganda and Zambia. And then the Ministry of Health selected 4 districts in each of these countries. The districts were poor and rural primarily. The initial phase was one of planning implementation plans and budgets in each of those districts. Then having a proof of concept period, which was 12 months of implementation. And within that 1 year, you remember the goal, we were to see some real changes to happen in those districts. One of the things I think was most unique about Saving Mothers Giving Life is that money, 5 years of money was not was not assured at the beginning. It depended on what kind of outputs, what kind of outcomes and results came out of that first year. Now, I can talk more about whether that was a good idea or a bad idea, but that's the context. So everybody was, all hands on deck. These are the districts. You see they're quite different. They're contiguous in Uganda, in 3 different provinces in Zambia. Have a little bit of the demographics there. Okay, before I pass the baton off to my colleagues who will talk about the end-line results, I just wanted to fit in really quickly a little bit about the results at the end of that 12-month period, because it's so fascinating, I think, the way that this was developed and how it played out. And so hang on to your hats. Here we go. What we found was a 30% reduction in maternal mortality in the districts in Uganda. We also found that there was higher satisfaction, the women who were interviewed. There was an increase in facility deliveries by 62%. And in the SMGL-supported facilities, there was a 35% reduction. I don't have it on this slide. So what about Zambia? In Zambia, we saw the exact same percentage in terms of decrease in facility deaths, 2 times greater satisfaction in the services provided at SMGL clinics and hospitals than in the comparators, and a 35% increase in women giving birth in facilities. The reason I wanted to sneak in these kind of interim results is that this impacted the goal and set the stage for what we call phase 2, and that's where we take the model and then we scale it out, eventually scaling it out to 13 districts in Uganda and 18 in Zambia. So this new goal, the 50% was continued. There's no aspirational in red next to it. And a goal for newborn death mortality reduction was also added of 30%. This sort of ends my introduction to Saving Mothers Giving Life and brings us up to how we actually implemented, and Diane will help us with that, and then the results. I would like to say I don't want this to be a conference where we all feel good and we think, yeah, this is great. Basically, it's a call to action. It's a charge that we may have some idea of some of the approaches that can find traction on this age-old problem. I also, in conclusion, want to thank everybody. Basically, I have a paragraph right now, and I think because I'm probably out of time, I just say a global thank you to all the people at so many levels who have participated in this endeavor. And all your names are at the end, the working group names and acknowledgments. We hope we've caught everyone are in the handout, so you can see if your name's there. And if it's not, tell me. We have e-posting, so we can make changes. But thanks from the bottom of my heart. I think SMGL, for many, was an opportunity to change the age-old narrative on the challenges that women face in the developing world. And I am so grateful to have been a part of that. We are appreciative, again, of all other people's efforts, and we feel that changing this narrative has been, for many, really a career-altering exercise. So thank you.
Thank you, Claudia. I'd like to invite Diane up to the podium. You know, one of the statements from the report that just stands out, and it's something that I've heard you say, and that is that women, families, providers, and policymakers no longer accept death during childbirth as a tragic but unavoidable part of life. And that's what this is all about, and absolutely. So powerfully said. Yeah.
Changing mores and, culture.
Yeah, absolutely.
Liquor thief. I hope it's kinder to you than it was.
How do you follow Claudia? Really? So I am tasked with that. But 6 years ago, the U.S. government and private partners launched Saving Mothers Giving Life, an extraordinary effort, as you've just heard about, with the governments of Uganda, Zambia, and Nigeria, to ensure rapid and dramatic reduction in maternal mortality. I'm honored to be able to participate in this remarkable partnership and its achievements, and to further discuss some of the approaches that we did and the implementation of SMGL. By now, hopefully, you are all familiar with the 3-delay model. And as Claudia mentioned, there were modifications to the model. It's not just focused on the complications, identifying complications and treating it with these 3 delays, but expanded. So I won't reiterate that. The supplement, though, includes 3 separate manuscripts, one each dedicated to the first, second, and third delay. Though 3 manuscripts are divided into these delays, it's really important to understand and to emphasize that these don't operate in isolation. Some interventions discussed here associated with one delay will also impact other delays. I'm now going to provide an overview, really just the basics, of each of these manuscripts with some examples of what's included within each. I consider this an appetizer. I'm pointing a laser instead of changing the slide. There we go. So the first delay includes numerous barriers that can affect a woman's awareness of a complication and making a timely decision to seek health care. These may include community, household, and health systems factors, factors related to the household or the woman's ability to recognize the need for health care. The example was perfect for the introduction this morning. She may have wanted to go to the health center, but her household had factors that inhibited her ability to seek that care. This also includes whether she will be able to have a birth plan in place, initiate the actions to reach care, and the factors related to the availability of the healthcare itself. The first manuscript focuses on this delay and examines the way that SMGL initiative focused its efforts to address the first delay and integrate its interventions within the district health systems in Uganda and Zambia. For the first delay, the main interventions and approaches align with 3 broad strategies. And you'll see this as a pattern. There are strategies for each of the delay papers, and then I'm going to provide examples of some of those strategies. Again, pointing a laser. The first strategy was to promote community engagement and empowerment for improved maternal and newborn health. The focus of this was to improve the individual's and the household's ability to recognize the need for health care. We didn't actually integrate Peace Corps volunteers into every household, but it sounds like that's a strategy we could.
You need more Peace Corps volunteers.
Yeah, clearly.
We had 18, though.
Yeah, you had 18, that's right.
The second strategy described was to increase birth preparedness, demand for facility delivery, and its use of preventative health services. And the third was to decrease financial and logistics barriers to accessing the facility delivery care. We wanted to share some examples of the activities. I get the fun part, get the pictures, right? That fall under each of these strategies. Each strategy used specific approaches, and they were tailored for each of the settings. So while the concepts might have been the same, we tried to really focus on what might work in that location. So this first strategy, which is promoting the community engagement and empowerment for improved maternal and newborn health care, was to improve the individual's and household's ability to recognize the need for health care. Here, now I can actually use the laser if I can find it again. Yeah. You see examples of the village health teams, or VHTs, in Uganda and Safe Motherhood Action Group, SMAGs, in Zambia. These community health workers help to sensitize the community on safe motherhood and connect pregnant women with facility-based care. Over 3,800 VHTs and 1,500 SMAGs. And just the volume alone is impressive. In Zambia, were active during the SMGL initiative. Evaluations conducted in Uganda and Zambia demonstrated an increase in facility-based care in the communities where these cadres were active. The second strategy highlights the focus on birth preparedness, including having a birth plan in place. SMGL partners engaged existing cadres of community health workers and mama ambassadors to conduct outreach and encourage birth preparedness and knowledge of danger signs. encourage the use of antenatal, postnatal care services, and increase the awareness of facility services for delivery. In this photo, well, here's some, and there, you can see an example of community meeting in the birth plan booklet, describing the danger signs during pregnancy or after birth, and the associated actions that need to be taken. The birth plans distributed in Zambia allowed each mother to fill in her personal pregnancy action plan. So they had a space to the side that says, in the event of any problems, I will do X, Y, or Z. So it was a written sort of formula for them to remember the actions. The third strategy focused on decreasing financial and logistics barriers to accessing facility delivery care. A variety of approaches were used to reduce these barriers, including distribution of mama kits, which had birth kits basically in both Uganda and Zambia, so basic supplies in the event that you couldn't make it to a facility, and the implementation of an extensive voucher system in Uganda to subsidize the cost of transportation. Initially, this was done for delivery services, but later was expanded to antenatal and postnatal care services. Pregnant women were able to buy these vouchers at minimal cost during ANC, directly from VHCs in their communities, and use them to reach the facility-based care. These examples just highlight a few of the many implementation efforts in Zambia and Uganda. Further information can be found in the first delay article in the supplement, entitled Addressing the First Delay through the SMGL initiative in Uganda and Zambia, Approaches and Results for Increasing Demand of Facility Services. The second delay. Interventions designed to address the second delay included the strengthening of referral systems in transport, improved communication tools, establishment of maternity waiting homes, and community-based systems to escort women to facilities. Many deaths are preventable by using 9 evidence-based interventions, the signal functions, which comprise emergency obstetric and neonatal care. The facilities may be classified as providing basic EMOC if they're able to carry out emergency obstetric care functions as administering uterotonic drugs, preventing infection with parenteral antibiotics and anticonvulsants, performing manual removal of the placenta, and assisted vaginal delivery, all of these to save lives. It's critical that women can access these in the case of emergency. The opening example was perfect in that setting, too. A woman with postpartum hemorrhage, had she not been in a place where she had access to treatment or prevention for postpartum hemorrhage and blood, there could have been a very different outcome. So there were 2 main strategies that formed the SMGL approach for the second delay. First was to decrease the distance to skilled birth attendants by increasing the number of obstetric and neonatal care facilities. So as Claudia mentioned, the mapping activities definitely played a role in identifying where these needed to be expanded. So you may have a facility, but it may not have the capability, and you have to expand the capability to get it to that level, or you may not have a facility at all. The second was to improve the accessibility. So even if the facility is there, if you can't get to it, it's not going to necessarily be able to help you to save that woman's life. A few of the examples. A myriad, again, of interventions were used to address Strategy 1 and decrease the distance to skilled birth attendants by increasing the number of EMOC facilities. SMGL interventions designed to address the delay make it easier for women to reach the care by increasing the numbers, as I mentioned, and the functionality. This photo shows a newly built surgical ward. Beautiful, huh? With even a rain shelter, which is wise. So in Uganda, as well as establishing maternity waiting homes. And there's an example of a maternity waiting home. And community-based systems to escort the women to the facilities. This is a newly constructed mother shelter. Previous shelters were constructed from mud or thatch and were very subject to seasonal rains. So having a permanent structure itself that provides a barrier against seasonal weather changes was huge for the ability of women to stay there and await their delivery. For Strategy 2's improved accessibility, which focused on transportation options, as you can see, the district ambulance, and access to transportation and communication. This district ambulance was provided by SMGL, which provided critical transportation to get women to a higher level facility where they could receive care. Again, these are just a few examples. I'm going to keep pointing you back to the supplement. I promise I have no financial investment, just personal and life investment, but not financial. The second delay supplement is called Addressing the Second Delay in Saving Mothers Giving Life in Uganda and Zambia, Reaching Appropriate Maternal Care in a Timely Manner. And this will also describe these interventions in greater detail and show you some of the outcomes of those interventions. And I bet you're not surprised, the third delay. The final manuscript in the delay series focuses on maternal and perinatal deaths due to the third delay, the lack of receipt of timely, adequate, and appropriate obstetric care at the health facility. We describe 6 main strategies. First was to ensure that the facilities have adequate infrastructure to provide emergency obstetric neonatal care. And as you can see from delay 2 to delay 3, some of these interventions apply to both. The second was to ensure sufficient medical supplies and equipment and medications. The third was to ensure sufficient trained healthcare providers at the facilities. The fourth, to improve the quality of care and ensure care is evidence-based. The fifth was to ensure that referral capacity exists to support transfers to a high-level care. If you don't have the capacity to do it, there may be an ambulance, but if you don't have the actual capacity to do it, they're not going to get where they need to be. And the final strategy was to support effective maternal, birth, and perinatal surveillance and response, and build that infrastructure for data collection and interpretation. I'm going to show you some examples. All right. Improvements in equipment, supplies, and number of staff, and staff mentoring were key to reducing the third delay. Examples of interventions to improve facility infrastructure, training, and supplies are seen in this slide. Through SMGL, there was a recognized need for blood, and First Regional Blood Bank in Uganda was open. I think, we did a lot of baseline assessments to see where gaps were. We could see from the data collection that there were obvious areas where interventions were needed, and that drove a lot of the political investment in making that change. Both Uganda and Zambia enhanced the maternal death surveillance and response data systems, as we mentioned, improving the quality of them and expanding the use of the systems in the districts. The information from implementing the MDSR in the districts formed the basis of the national guidelines in Uganda, and those are shown on the left. So while this was an organic effort in some senses, we had ideas, we worked with partners to determine how these data systems could be expanded. That went on to become the national mainstay, so it was incorporated. We tried to really build off the platforms that exist, do it in a practical way, and have that intervention be sustainable. And so to me, this is, from a data perspective, because I'm a bit of a data wonk, this is one of the really key evidence that there is a sustainable difference. It's a national policy. There are national protocols. There are national guidelines. There are these, as I noted, were a few examples of the interventions to improve the third delay, and they just really scratched the surface of what SMGL accomplished. Further examples, no surprise here, are found in the third delay paper, which is entitled Addressing the Third Delay in Saving Mothers Giving Life Districts in Uganda and Zambia, Ensuring Adequate and Appropriate Facility-Based Maternal and Perinatal Health Care. Now, I know I've just scratched the surface, and in 20 minutes and 9 slides, there's only so much I can accomplish. But I'm hopeful that the appetizer worked and that it'll lead you to think further about these delays and the implementation in SMGL. I really want to thank the other lead and co-authors. I'm representing them for each of these delay papers. And the other authors of the manuscripts, not just the leads, but everyone who contributed to making this possible. And CDC colleagues such as Susanna, who's here, for their assistance in the presentation and their use of the photographs. And I have absolute appreciation for the in-country partners, the people on the ground, the communities, and the women and families involved in this initiative. It would never have been possible without that level of engagement, really from the grounds up. Without their passion and the countless hours spent working on this project, we would never have had the incredible success that we did. And now for the exciting results, the main course, I'll call it, or maybe the dessert, to be presented by Dr. Serbanescu.
While you're getting set up, I just want to reinforce the message
7 minutes or 5 minutes?
No, you have a few more, actually.
Thank you.
Diane.
Was it okay on time?
Yeah, you're perfect on time, so we're fine. We're right on time. But I think it really just reemphasizes the fact, and this is the tagline of Saving Mothers Giving Life, that it takes a health system to save a mom and a baby, and it really, truly does. It's a combination of all those interventions together that makes a difference.
Thank you so much, and thank you for the previous presenters to cover so in great details the concept, the theory of change, the approaches to combat the 3 delays, and for giving you the understanding of interpreting the results that I'm going to present. So before of that, I would like to thank the organizers and the journal who has worked valiantly with us over 9 months to bring to fruition this extraordinary supplement. And I want to thank all of you here and online for being here today to discuss the impressive results of the initiatives in Uganda and Zambia. Now, we at CDC are known for our work on epidemics like Ebola and Zika, but together with USAID and country partners, we took on another epidemic, an epidemic of women dying from maternal causes, which are overwhelmingly preventable. We are proud to be part of the SMGL partnership and that aim to reduce maternal mortality by half in the pilot districts in Uganda and Zambia. As challenging as it may be, this was and continues to be an area in which we together can have an enormous impact. Simply put, it's a battle to choose because it's a battle that we could win. And by the way, CDC has winnable battles all over it. Now, SMGL implemented strategies for which we have strong evidence of success, brought these strategies to scale, and implemented strong evaluation plans to monitor our progress and make sure our programs in facilities and communities are working and have the greatest possible impact. Now, my first slide describes the array of robust monitoring and evaluation approaches that SMGL implemented in Uganda and Zambia. I don't think you can see the small print, but you can see synergy in implementation of both data collection in communities and in facilities. And I would like to point out that more detailed description of these methodologies is in the impact paper of the journal. So at the community level, we conducted baseline census-like data collections in the 4 pilot districts in Uganda and 4 pilot districts in Zambia. That included enumeration of all households and all vital events in these households, including deaths to women of reproductive age. These deaths was followed with verbal autopsies to establish if the death cause was maternal. In Uganda, that methodology transformed into a continuous maternal death surveillance and response process that is now a model for the entire country. In parallel, data collection in facilities, in addition to doing needs assessment, included quarterly data collection of pregnancy outcomes and complications, surgeries, and death events for mothers and perinates. This was done in conjunction with community events. So every single year, data were reconciled between facility reports and community reports. Now, that was the only way we thought about, which was not an easy way, was a very complex way, was an expensive way, to be able to demonstrate an overall reduction of maternal mortality in this pilot district. We needed to know what was the maternal mortality at the beginning of the initiative, and we needed to know what was the maternal mortality in the index year, that was 2016, in order to see how far are we into reaching the 50% decline that we started to want. So these are countries with high maternal mortalities to begin with. And these are countries that do not have direct measurement of maternal mortalities, like many, many countries in low and income country area. We documented a maternal mortality of 452 maternal deaths per 100,000 live births at the baseline in Uganda, that dropped by 44% to 255 maternal deaths at the end line. In Zambia, the starting baseline maternal mortality ratio was 480 and dropped to 284 maternal deaths. Now, this was a decline unprecedented in these countries. If we look at what is estimated for maternal mortality by global estimates, by DHS surveys, there is about a 3% annual reduction rate in maternal mortality in Uganda and Zambia. Our annual reduction rate was close to 11%. So 3 times more than the average reduction. That is still a very good reduction. Now, the goal of the Sustainable Development Goals is to have no more than 40 maternal deaths per 100,000 by the year 2030. This reduction here shows that it is possible to accelerate maternal death decline, but countries need to step up their efforts to do that. So today, this initiative in Uganda and Zambia has been scaled up in several other districts in Uganda and Zambia, and we offer this model to be replicated in other countries where maternal mortality is high. So this slide shows the direct obstetric maternal mortality ratio at baseline with the dark blue and end line light blue in Uganda. You see that all causes of maternal death decline. The overall reduction in MMR due to direct obstetric causes was 49%. So we were really, really very close to a 50% reduction. The indirect maternal mortality was not affected by the initiative. You will see the figures in the publications. There is a decline, but it's not significant. So the driver of the maternal mortality reduction, as we expected to be based on the interventions we implemented, was a reduction in the main killers of mothers, which are obstetric hemorrhage, obstructed labor, including uterine rupture, eclampsia, preeclampsia, postpartum sepsis, and complications of unsafe abortion. Now, in Zambia, we also see very, very significant declines and strong declines in obstetric hemorrhage deaths and in obstructed labor deaths. The other causes of death are not showing significant declines. We surmise that that is also due to the fact that we didn't have enough power to demonstrate a significant decline. So what was the driver of reducing maternal mortality? Improving demand and access to health facilities was a central strategy of SMGL. Delivering in a facility greatly improves the chances of surviving childbirth. Facility deliveries increased by 47% in Uganda. That started at 46% at baseline to reach 67% at endline, and increased by 44% in Zambia, from 63% to 90%, which is very high.
Yeah.
Now, it is, I would also comment that in Uganda, the districts where we started the initiatives had lower than average skilled birth attendance or institutional delivery rate than the rest of the country. Whereas in Zambia, the original districts had about the average country institutional delivery rate. In addition to increasing the number of women who came to facilities to deliver, facilities were better equipped to deliver emergency obstetric care. In both countries, the number of facilities providing EMOC doubled, more so in Uganda, where the initiative renovated or built 10 additional surgical wards, most of them in health centers. And you have seen a picture of a health center, a model health center with a rain cover, but with staff 24/7 and totally prepared to handle any direct obstetric complication. So this led to more women accessing EMO care in these health centers that decreased the need for them to be referred to overcrowded hospitals. Another critical component of emergency obstetric care is the ability to perform C-section deliveries when necessary. C-section delivery rate increased significantly in both countries by over 70%, from 5.3% to 9% in Uganda, and from 2.7% to 4.8% in Zambia. These are well within recommended levels, and there is still probably more need for increase in Zambia. This slide probably would have benefited from a visual expert. However, we were given the mandate to present everything in the fewest possible slides, and I apologize for being so busy. But at least it's easy to read if you concentrate on one cell at a time.
That's right. That's right.
All right, then. So on the left side, you see main facility impact indicators, and then the first panel is Uganda, and the right panel is Zambia. So I'm going to work through these numbers horizontally. So the first couple of indicators are maternal mortality indicators. Maternal mortality in facilities is different from the overall maternal mortality. It can be higher or can be lower than overall mortality. It depends on when women go to the hospital and where women die. So we see a decline of 44% in Uganda and 38% in Zambia, both very significant. But the numbers here are quite different than what you've seen on the previous slide. One of the driver of reduction of maternal mortality in facilities is reducing case fatality rate. Case fatality rate is supposed to be ideally no more than 1%. What is case fatality rate? It's the number of women who are suffering of direct obstetric complications and receive care in facilities. So if they died before discharge, they will contribute to this indicator. So the case fatality rate declined significantly only in Uganda by 37%. It is a tendency of decline in Zambia, but the decline is less, and the case fatality rate is higher. Now, the next four indicators are indicators of perinatal mortality. And perinatal mortality refers to death of a baby from 28 weeks intrauterine life to first week of delivery, and is a reflection of the status of antenatal, delivery, and newborn services. This is perinatal mortality in facilities. Do not make any mistakes. We are not measuring overall perinatal mortality levels and changes. So the rates in both countries were very high at the baseline, 39 and 38 in Zambia. These are very high perinatal mortality rates. However, the declines were significant in both countries, a decline of 13% in Uganda and 26% in Zambia. What is not very favorable is that this decline is primarily driven by reduction in total stillbirth rate, and really, as we can see from Uganda, in the decline by the decline of fresh stillbirth deaths. So mortality to neonates, the pre-discharge neonatal mortality rate has not changed through our efforts in health facilities in either country. You'll see a decline in one and an increase in the other. None of these are significant. Well, so SMGL has undeniably raised the bar in how we address maternal perinatal mortality. The achievements show that what is often seen as an intractable problem can be addressed with the right leadership, resources, and political will. SMGL led to remarkable results in maternal perinatal health in the pilot districts. Its momentum in Uganda and Zambia, where the model was already scaled up to many other districts and impacted national policies, has been unstoppable. Thousands of people's lives have changed for the better because of these efforts. In addition to a model of successful interventions in facilities and communities, SMGL built capacity and infrastructure for real-time measurement of pregnancy outcomes and vital statistics, which will also address other important causes of burden of disease. Please join me in applauding these results and that constitute an impressive and lasting SMGL legacy.
Thank you so very much. I appreciate the efforts of all of our panelists. And so now is the time for Q&A, so I hope all of you have some questions in mind. I'm going to actually use my prerogative to ask one question to each person and then give you more time to think, although I can see lots of hands already. And we're going to bundle questions a little bit and then allow people. Actually, what I'll just do, because we have so many hands up there, I'm just going to ask a question and then I'm going to take a few more questions. Please, when you ask your question, say who you are and your affiliation, and then try to direct it to a particular individual rather than just opening it up to everyone, because otherwise it just takes a lot of time. So I'm going to ask a question to each person and then we're going to take a few more. Claudia, we were able to really describe each of the different interventions that were so important in addressing the 3 delays. But I wondered, you know, there are still challenges that need to be surmounted, and I think we have seen in terms of the results that some of the places we weren't as able to make a difference. And so my question is, what are some of those challenges that we still need to address? And then maybe you can talk a little bit about, you know, what were some of the enabling factors that that enabled you, that were already present in the culture and the society that enabled you to. So that's one question. For Diane, I am really very interested in how some of the interventions were selected and prioritized, because in some places you use, for example, transportation vouchers, other places we use maternal waiting homes. I know there was rationale for those, so if you would talk a little bit about that. And then, Florina, I'm wondering if you could talk about the SMGL interventions to improve family planning, because that's, of course, such an important driver of reducing maternal mortality. And I know that's something you're also very passionate about. So those are my 3 questions. I'm going to gather a few more, and then we're going to allow each person to have a little bit of time to kind of weave them together. 1, 2, 3. First, you. Say your name, please, and where you're from.
Jill Gay, What Works Association. My question is for Florina on, could you elaborate on what actions were taken to reduce complications from unsafe abortion in Uganda?
Good, thank you.
I'm Indira Narayanan, an independent consultant in maternal and newborn health and an adjunct professor in the Georgetown University. One is a remark that I would like to make. It was a wonderful set of presentations and fantastic results. Those of you who know me will forgive me for this remark, but my passion is for newborn health. I realize it's very closely linked with maternal health, but when we say maternal and newborn health, we have to make sure we're addressing interventions that deal with the newborn. One of the important factors which you have highlighted in these presentations is that you managed to reduce stillbirth rate because you addressed the labor, delivery, antenatal period. But when you decrease stillbirth rate, you will actually increase the problems the newborn will have, because now the newborn is surviving after having gone through a very difficult phase. So unless we address specifically the care and quality care of the newborn, we will have the problems that you have highlighted, that you've not been able to decrease neonatal mortality.
Right. So that's a great question to some of our panelists, I think,
So
is what
is that
exactly?
something that you would like to address if you're going to have a follow-up program on this? And it isn't only addressing the birth asphyxia, because even training alone doesn't help unless you have good quality mentoring after that. But you also have to make sure your facility is ready for the care. I've recently just assessed the newborn care.
Yeah, I'm so sorry, Indira, but I think that I really appreciate that, and I think that I'd like to ask one of our panelists to also address the issues of interventions and perhaps additional research needed around the neonatal care and survival. And one more question over here. Yeah, Mary Ellen.
Mary Ellen Stanton, USAID. Thank you so much to the panel. I'm wondering, I think this is for Claudia, knowing what you know now, if you were going into a different country that wanted to accelerate progress, what you advise specifically on the question of whether you would go nationally to apply the principles and what you've learned, or whether you would use the approach of pilot districts and spreading out as occurred here. And particularly along with that, if it's a pilot district approach, comment on the contrast between Uganda and Zambia in contiguous districts and spread out districts.
Mm-hmm. So I'm just going to summarize for the sake of our panelists. So Claudia, you've got a couple of questions, some of which are perhaps bundleable easily, is the challenges that need to be surmounted, some of the enabling factors, as well as advising specifically on whether you would go for a national application or pilot districts and whether or not contiguous districts is a strategy. Mm-hmm. For Diane, maybe you can take the question that Indira raised around the newborn health. I know this is something that you really care about deeply, have done a lot of research on, as well as how interventions were selected and prioritized. And then Florina, if you would talk about both the family planning, but then also actions for unsafe abortion, this was raised. So they fit nicely into buckets, and I appreciate very much the questions.
And you fit them nicely into buckets. Good job. I think I want to sort of disabuse folks into thinking that SMGL created a maternity utopia in Uganda and Zambia. Maternal mortality ratios in these countries, even in the SMGL districts where we were able to save lives, they're in the high 200s. Depending on who you ask, or the low 300s. That's not utopia. What we are hoping to do is give women a fair shot at living. So I don't know that I will answer questions about what is there left to do. There's tons left to do. I think the approach of looking at the system and the perturbations of the system and adding interventions to strengthen the system, having that mindset and the champions and the ability to mobilize funding to do that will eventually lead us to a world where women do have a fair chance at living through their pregnancy. The challenges so I think the system or the approach is a good one, and I think it's operable in many low-income situations. What I think were challenges particularly that I identified within SMGL were more challenges in how we worked to apply the knowledge that we had or the system that we wanted to. Just some examples of real challenges. The original planners said we are only going to assure funding for a year. And not only was it only for a year, but having any additional funding was predicated on the ability to show unbelievable levels of change in maternal mortality in this truncated 12-month period. So that created a lot of frustration during the proof of concept period, 12 months of implementation, but then it required an additional 5 or 6 months to get the data, analyze the data, and understand what had happened. So for about 5 months during that process, there was chaos. It was difficult. And there were difficulties in terms of what do you say to people who are continuing to work because they themselves believe and they see at the clinic level that women are living rather than dying. Mm-hmm. So I think that's something that from the get-go, these kinds of efforts should be long-term, longer term. I even think 5 years is a short term for something that for millennia has been kind of we've been unable to push that dial. One of the other problems I think that we had was erratic funding. With public-private partnerships, you've got different organizations with different bottom lines. They maybe have different definitions of success. They have constituencies that they have to meet their needs. And so it takes the notion that there's going to be predictable funding to be able to move forward and do the work that needs to be done. And I have to say that there were several periods where the funding was not available, and that was difficult. Probably the last thing is just the management burden. It's like playing 3D chess. You've got so many different organizations. We had 39 implementing partners in Uganda and Zambia, and because the results, we wanted to have them immediately, we had to basically tell folks, all right, you start running, you've got a work plan for something, and we will need to forge that into this force for change. And that took a tremendous amount of effort. Robert and others who were engaged in that understand that. And we think that the partnership itself, there are different ways that partnerships can be organized to address these issues, but I think I'd be remiss to leave the feeling that there weren't issues that had to be addressed. So those are the 3 challenges that I can think of. The Uganda versus Zambia, I think contiguous districts really made a difference. You get a lot more, your ability to use scarce resources is enhanced when you have all of the action in one area. So I would recommend, to your initial point, I don't think starting nationally is the way to go. For me, change is always about people. It's always about people. And so in order to find those champions, in order to find the people, the parliamentarians that are willing to stop a national budget, as 3 parliamentarians did in Uganda because they didn't like the wage bill. They wanted to change it to make sure that doctors would work in rural health centers, not just in the city. So they stopped the bill. You need those kind of champions and those kinds of relationships so that with a pilot period, building that up, other people seeing that, hey, this works, even across traditionally, lines where there may have been struggles, particularly in agencies. It requires that level, I think, of intensity and then scaling up nationally. But it's doable. Yeah.
Diane?
Great. So when thinking about the interventions and how do we determine them and how do we prioritize them, there were core principles that were applied. We wanted interventions that addressed the delays based on the model and being mindful of the 2-hour time frame that you're looking at. We wanted interventions that would strengthen health districts that were based off of governmental ideas. So there's sharpening plans or fundamental documents for the way forward in MCH. And we looked to those documents and built off of them. To build capacity for the local interventions to be implemented, and to really try and work with the private sector as well, where at all possible, whether that's non-for-profit, faith-based, NGO sectors, what's in place there. And as you saw with the non-contiguous districts, the characteristics of both of these settings are quite different. There's a farther distance to care in the majority of the settings in Zambia. So things like maternity waiting homes were prioritized over vouchers because it was seen as more feasible to intervene, more bang for the buck. It was appropriate culturally. There already were some maternity waiting homes. In Zambia and Uganda, you had closer distances to care. And while there were maternity waiting homes for people who lived far away, really it was the shorter distances and the ability to access difficult terrain, especially in rainy season, that may have been a bigger barrier. So they were tailored to each of these different settings. And then for the capacity to capture data and analysis, most of the countries have a national data system, but trying to build off of that system to get more robust data that could then be used to inform interventions downstream. When I'm thinking about the neonatal interventions, there actually were quite a few neonatal interventions. More of that began in phase 2. It was really expanded in phase 2. Additional funding was obtained from private partnerships in phase 2 to do more of these interventions. Things such as helping babies breathe, neonatal intensive care units, kangaroo mother care were implemented in many of the facilities. Additionally, for data collection, and I admitted freely that I'm a data wonk, you had facility-based data collection in the form of a baby's matrix, which looked at the outcomes of delivery and the weights of these deliveries, and tried to help facilities categorize what's really going on. And it's designed to pair with interventions that can be applied in the facility. So as that got expanded specifically in Uganda, people became much more aware of the situation. And that takes time to not only become aware, but to link to what interventions should be done and are we doing them correctly? Do we have the support and mentorship? As you mentioned, mentorship's critical. Making sure that people know what to do, doing it correctly, and are followed by people who can support that. Florina also mentioned the neonatal death surveillance and response system it was the NDSR platform. I'm thinking specifically in Uganda, that was expanded, but it actually kind of became a perinatal death surveillance and response because you have a death captured and it's not always clear what's neonatal and stillbirth, especially in the community settings. And I think as more attention is built around this and as more people are focusing on it, we may get better numbers and better ideas from those verbal autopsies and from those systems on where to intervene and which delay this affecting, at least for the community. So I think there's a lot of skills building that still can be done. It's hard for me to completely know where in the spectrum are we? Is it that these interventions are being done, but they need to have better quality? We need to have better measurement in it. We need to have better skill building. I think it's newer in the greater scheme of the whole initiative for the perinatal focus. And so I look to that opportunity to really focus on that a bit more and expand it.
Thank you, Diane. I think it's live.
I think it's on. Pick Diane's.
Yes, this is on. So just quick add-ons to my esteemed colleagues' responses. Mary Ellen, we have been building our monitoring and evaluation from scratch, which it was incredibly difficult and painful, and we learned a lot, both good and bad, do's and don'ts. And I think it's okay to offer if someone wants to go through such an ambitious model that includes community monitoring and facility monitoring. We'll be more than happy to share our tools and documentations and instructions. And more to the point, we worked with people who have probably no more than 4 years of education at the community level. So our trainings are adapted for an audience that is more visual and more hands-on approach than talking theories of monitoring and evaluation. So please, particularly in Uganda, where community surveillance had been established and is running, both for maternal mortality and, as Diane mentioned, for neonatal or perinatal deaths, although these data were not presented today, we have a lot of things that we like to share with the world. So if anyone would like to have a glimpse of these tools and training materials, we'll be happy to share. The other things that I wanted to mention is that we would hope to maybe later when we have time to absorb the results from the perinatal mortality surveillance in Uganda. With another occasion, we'll share with you the results, because these results are not yet ready. And my question that was from Carrie and from the audience is, what did SMGL do to improve family planning support and uptake in Uganda and Zambia? Although family planning was not spelled out as a core contributor to maternal mortality reduction, we have always assessed the capacity of facilities to provide contraception and provide comprehensive post-abortion care. We also assessed post-abortion complications as a cause of maternal mortality. So in both countries, the supplies of long-active contraceptive methods have doubled, huge increases. In both countries, although through partners' efforts, manual vacuum aspiration supplies were stocked in all health centers and hospitals. Hospitals also had received donations of electric vacuum aspirations. And we also made sure that women in communities are aware that if there is a pregnancy loss, there is help, and there is totally okay to access health facilities to receive that help. So I want to highlight that the decline in maternal mortality due to post-abortion in Uganda is very, very clearly linked with the elimination of severe abortion complications. It doesn't mean that abortion procedures or evacuations did not occur, but none of these women sought help in a very late stage. So the life of their the complications can be treated, and death was averted. And I would like to end with a story from Zambia, where I was visiting a health center, which was in Kalomo, which was near a high school. And every single year, that health center reported 2 or 3 maternal deaths to a student in that high school. And when we were there, after the first year of implementation, they said that for the first time, they feel that they are finally able to help these students and avoid what such a tragical loss of a young life. And they went to the school and made sure that the school knows that now the health center has the ability to provide family planning. So I don't think that the reduction in maternal mortality ratio captures well the family planning interventions, because it's a measure of obstetric risk and not so much a measure of the rate of mortality among women of reproductive age. If we would measure that, we'll see a decline as well. Thank you.
Thank you. Thank you for ending in that story. We are just about up. I want to give Claudia one more really quick opportunity. This came in from Twitter. This is from Vanita Gupta from URC, asking about key strategies for advocacy to encourage replication and adaptation of these results besides right here. Is there a strategy for advocating more broadly, or how can USAID use its considerable platform to make sure that this is scaled up?
Yeah, I'm happy to say that the leadership of the Ministries of Health in Zambia and Uganda both endorsed this systems approach. And in Zambia, there is now a bilateral called the Continuum of Care, which uses the SMGL systems approach but adds on other continuum, more emphasis on the newborn, more emphasis on ANC, and also through the child. And this is being funded by USAID with DFID funds, UNICEF, and it is going to cover by 2020 6 of the 10 provinces in Zambia. So we said that national scale up would be, if we got to 70%, we would call that national scale up. So we'll be very close to that percentage in Zambia. In Uganda, I was at the meeting in Mexico City, the maternal newborn health meeting, and Jessica Sabaiti, who is high up in the Ministry of Health in Uganda, ran up to me and said, Claudia, I just want to let you know that we used the SMGL, basically systems approach, to inform our sharpened plan for the GFF. They were in, I think, the second round of the GFF group. And so we've worked with them on ensuring that the ability to focus on how one would do this program in the various districts within Uganda, that's a possibility. The fact that the voucher program in Uganda is the basis for the national voucher program that has come out. The fact, as I said, that this top-off of salaries for doctors to get them into the rural areas, that became the wage bill and that was passed. Yeah. We see, and I think Marianne will be speaking on sustainability, so I don't want to steal your thunder, but I'm sure Marianne will have many other examples of why we feel that we have not only a toehold, but that this approach will move forward. Also, RFAs, RFPs, putting the importance of incorporating some of these organizing principles into the USAID RFPs, RFAs. I think that's totally doable as well. So I think there are lots of avenues, results-based financing. People are crying for models in order to, bring areas up to a certain level so that they can be considered, eligible for results-based financing. This is one way that also could dovetail. Right. So there's lots of ways that we're thinking about. It's not branded SMGL, and believe me, I'm not looking for another 5 years. But it's a way of thinking and approaching this problem, and I think it does have traction, and we will continue to work on that.
Thank you so much. I mean, that was a great sort of summary of what we've learned. I mean, I just want to say that SMGL has really demonstrated the importance of the systems approach. I think there can be no longer any question that this is critical to the future. But as you pointed out so aptly, Claudia, there's so much more to be done, and we need so much more investment in this area. And again, finally, this is all about people. Every single one of those deaths is a real family that is unalterably changed in such a tragic and traumatic way. And yet, if you look at the results, 197 per 100,000 women in Uganda are alive today because of this intervention. And in Zambia, it's 196 per 100,000 women. Those are real women and their families behind these statistics. So thank you so much for the work you do. Thank you to all of you, because all of you dedicate your life to this issue as well. And it's such a privilege to be among you. So thank you. To our panelists. Thank you to our panelists. We have 3 minutes to make the change.